The content of this podcast is provided for general informational purposes only and is not intended as, nor should it be considered a substitute for professional medical advice. Hello, this is Karen Nickel, family nurse practitioner, and you are listening to Itchy and Bitchy, a podcast that provides answers to your many unanswered health questions. As I mentioned in the last two episodes, after 9 years of hosting Itchy and Bitchy, it is time for the podcast to grow and evolve with new hosts and a slightly different format. And remember that growth and change is a good thing. My dear friends Stephen Miller and Keith Hnilica will be the future hosts of Itchy and Bitchy. As hosts, they will have a comprehensive approach to wellness with a focus on connecting human health, animal health, and environmental health. To provide a transition period for you, for me, and for Stephen and Keith, we have a series of 4 episodes planned. This is the third of the 4 episodes, during which I will be interviewing both Stephen and Keith. Dr. Stephen Miller is an acute care nurse practitioner known for his expertise in diagnosing and treating cardiovascular disease, and Dr. Keith Hnilica is a veterinarian and board-certified veterinary dermatologist who has been in practice for 30 years. To learn more details about them and their expertise, make sure to listen to the episodes dated April 4th and April 11th, 2026. We are going to talk about hormones today, specifically about estradiol, which is the most potent form of estrogen in a woman's body. Menopause occurs when the ovaries stop secreting estradiol or when the ovaries have been surgically removed. Recently, the black box warning on HRT was removed, and this is a big deal. I've talked about black box warnings before, but as a refresher, this is a bold black bordered warning that is placed at the top of a medication's labeling. It alerts healthcare providers and patients to serious, life-threatening, or permanently disabling adverse risks. The FDA announced the removal of the black box warning from most menopausal hormone therapy products on November 10th, 2025. This serious warning was placed on HRT in 2002 when the Women's Health Initiative study, WHI study, which, by the way, was a poorly designed study with misinterpreted data that led practitioners to stop prescribing HRT for their patients. So now, 24 years later, the FDA finally took the step to right this wrong. But it took 24 years. I've said it before, this culture is very tolerant of women's suffering. Probably in light of recent studies touting all the benefits of starting HRT early in menopause, the FDA determined that the WHI study warnings of risks like breast cancer and cardiovascular disease were overstated. The new and improved labels highlight the benefits for women under 60 and within 10 years of menopause. Well, hello. As soon as the black box warning was removed, all of a sudden, practitioners felt more comfortable with prescribing HRT. This after women were frequently told by their practitioners that it's just part of life, something you'll have to get through. Buck up. This surge in prescribing led to shortages of estradiol patches in the pharmacy. Keith, what are your thoughts or comments on the history I just shared and the consequences of how HRT has been handled for the last quarter of a century?
All right. So I'm Keith Hnilica, Dr. Hnilica, just a veterinarian. So real no pony in this race. But I was listening to one of my favorite news episode podcasts, and the story came to light. And I just thought, what is going on? In the medical world, a black box warning is basically a death knell for a drug. So, and a lot of drugs that actually have pretty good efficacy and even few side effects can get a black box warning for a variety of reasons, oftentimes because there's a serious concern in side effects. It dramatically communicates to the providers that this can kill your patients. And so they stop using the drug.
Right.
For 24 years, this drug had a black box warning. So they reviewed the literature, which is good. Always progress, and we're going to do some meta-analysis.
Reading is good.
How big was the review of this study? It was big. We talked before on the last interview that in dogs, a lot of our studies are like 12 dogs, 25 dogs. This was like thousands of patients, right? So they decide that it's actually pretty good for you. HRT is maybe a good thing.
Say what?
But then, now that it's a good thing, women can't get it. And if you can get it, it's 3 times the cost. And it's like, what the freak is going on here? So I'm not a big conspiracy theorist, but if I was, this would fit the bill.
So I'll give just the slightest amount of pushback. Yeah. So this is
Stephen.
Stephen
jumping
Miller.
in to add, which I appreciate. Stephen Miller.
From the male perspective, but from the gay male perspective. So I don't know. It could be different.
With daughters.
With daughters, yes. So a little pushback in that they come up with a statement basically saying they do a comprehensive review of the scientific data, right? And so the issue came down to divergent outcomes and looking at divergency between estrogen alone versus estrogen plus progesterone. Truly, I think that is deserving of some adjudication. I'm not sure 24 years of adjudication, but so that's one point that I think needs to be considered. The other point is that reviewing and looking at the timing hypothesis, which we really didn't deal with before. So the timing of treatment either in pre-60-year-old women and favorable risk-benefit profile. Again, I'm not sure 24 years that's a really long time, but certainly I think that's worthy of mention.
So subdividing the population into, are you a 30-year-old person, a 60-year-old person, a 90-year-old person? Is that what you're talking about?
Yes.
Okay.
You mean in the study or?
Yes. So in the retrospective review of this analysis, comparing the Women's Health Initiative with more recent evidence, the timing hypothesis evolved, right? Because before then, it was just estrogen for everyone.
Well, but in the WHI study, this was one of the faulty pieces of the design, is that they started women who had never been on HRT.
Right.
They started them on Premarin anywhere from age 68 to 73.
Yeah.
And we don't typically do new starts of HRT on a 73-year-old woman. Not typically.
Right.
So it was a bad setup.
It's a bad setup, and I totally agree with that.
Thank you.
And 24 years is a long time.
So almost a quarter of a century, women have had to deal with being taken hormones away, and with the fear of cardiovascular implications. So then there was the third panel point, which was that they needed an expert panel deliberation and a 60-day public comment. And I get it, because there are a lot of different bodies of expertise that needed to weigh in on this. And then fourthly, acknowledging that warnings were based on incomplete data. And this is the point with the Women's Health Initiative. It was incomplete data set. So they were looking at putative harm and secondary outcomes, and they weren't looking at primary outcomes in those
Are we
groups.
talking about WHI?
WHI,
okay.
Yes. And so they were inappropriately extrapolated those outcomes.
Correct.
I think that's a really key thing that I think if I were a listener, I would want to know about clinical trials across the board. Is inappropriate extrapolation of data across populations really becomes a big deal. And it doesn't matter if it's hormone or whatever. But in this situation, we're talking about HRT. So that was my little bit of pushback, in that there were some valid points, but 24 years is a really long time.
WHI was on conjugated horse estrogen, and they did do some of the study on Primpro, which has conjugated estrogens and progestin. And a lot of providers mistakenly use progestin and progesterone synonymously. And progestin is a synthetic version of our progesterone and has a bunch of risk factors, especially clotting. Our own natural bioidentical progesterone does not have the same risks that progestin holds. So I just want to make it clear to our listeners that progestin is a very different thing, and don't let anybody tell you otherwise, because there are a lot of providers who still don't know the difference, believe it or not. A lot of GYNs who don't know the difference between a progestin and progesterone.
And hormones are complex. I mean, they really are a very complex, metabolic, interactive kind of system. I want to go back to my outrage, though.
So you go.
Okay. So 60 days, I've worked for pharmaceutical companies, and in 60 days, they could easily have ramped up production, knowing that the FDA was probably going to open up and release this black box nightmare limitation warning. And so what is up with not being able to get these patches, right? The patch is one of the leading ideal fewest side effects type therapies. And I want to ask you about side effects in a second. But why didn't the pharmaceutical companies ramp up and like, what's up with that?
Well,
Karen, you're supposed to have the answers here.
Well, yes, I do, but they're usually
not good.
Angry type
capitalism.
answers.
It's capitalism.
Answers.
Right.
Well, I think we don't think ahead in these things. I think they didn't expect. I'm sure that practitioners would start writing them like it's handing out candy on the street corner.
So along those lines, that now the prescription rate for estrogen patches is skyrocketing because it's now safer. We understand the limitations. And so women now have access if they can find the product.
Right. Well, and I think for the audience, I think it's important to state that the transdermal patches are preferred over oral formulations, right, Karen?
Yes. So you're the expert, Karen. So tell us what's what with the modality of administration.
So there are multiple benefits of topical estradiol over oral. Number one, when you use a topical estradiol, whether it's a patch or a cream or a gel or intravaginal estradiol, it does not have a first pass through the liver. And during that first pass, what would happen, and this is what happens with oral estrogen, when it passes through the liver, we produce more fibrinogen. And when we have higher levels of fibrinogen in our blood, we have increased risk for clot. So by doing it transdermally on the skin, in the vagina, then we significantly reduce clot risk because we do not increase fibrinogen levels with topical estradiol.
What topicals are you talking about? So you have a patch, you have a cream,
gels, intravaginal, like if you did a vaginal cream that would be compounded, but we have vaginal rings that have estradiol in them.
Like a slow release, maybe?
Yeah, you insert it vaginally and it releases for 3 months. And so anything that is not directly going into the digestive system.
Okay, then Dr. Miller, side effects.
The biggest scary thing is the increased risk for venous thrombosis. And then the historical fear was moderate cardiovascular risk associated with oral formulations. But then there's also with that transdermal, avoiding the hepatic first pass is the issue related to elevated lipids. So you don't have to worry about hypertriglyceridemia when you do the transdermal formulation. So there are differences. And I do think historically, when we go back to the Women's Health Initiative, that evidence was poorly understood, and so there has been some really positive things to come out of this period of time that we've waited, not 24 years.
So would you say
he's
oral,
watching me glare at him?
Mm-hmm. Yes. Would you say oral is more risky and bad and topical transepidermal is better, fewer side effects?
Absolutely. Well, first of all, if you're using something like a patch or the vaginal estradiol ring, or even creams or gels, but especially a patch or the vaginal ring, it's a slow, even release. So you're going to have fewer breakthrough symptoms like hot flashes and night sweats because you get a more steady estradiol state that's going into your bloodstream and then into your tissues. So that's a big advantage too, because we have a natural fall off of levels when we use something orally because it has to go through our digestive system. It breaks down a lot of it. So as a matter of fact, because of that, we also have to use much higher doses. Yeah. So we get the same effect after we lose a bunch of it in our gut. For instance, if I were compounding a estradiol cream and someone was on a tablet or some form of oral estrogen, we would cut that dose in half when we convert it to a transdermal form.
How often do they have to put on the cream or a patch?
Well, the cream or gel is usually once or twice a day. The patch is once or twice a week. We have patches that are twice weekly that are quite small, which is nice. The once weekly is easier for people, but that thing at the highest dose is about as big as this coaster that's on the table next to me.
4 inches.
It's a big
4 inches. Yeah.
It's a big thing. Typically people like the twice weekly dosing because it's a much, much smaller patch and it's clear. The once weekly is usually a flesh colored, and that's fine if you're a white person because it's that color.
Yeah.
But maybe not so much
again,
if you
capitalism
are a person of color.
So what I've heard that the availability of the patches is very difficult now because of the demand, and I think they come in different milligram doses. And then I've heard of people cutting them in half. It just desperation to. What do you think about that?
Yes, you can cut patches in half. Absolutely. You might have a little more difficulty getting it to stay in place. But personally, I cut my patch in half.
So you would go up a milligram dose and then cut it in half. Yeah,
so for instance, I'm getting super personal, but I have a prescription for a 0.05 milligram patch, and I cut it in half. So I have a 0.025. 0.025 milligram patch is the lowest dose we have. And then it goes up to 0.1 milligrams.
And this, I assume, at least my patient's veterinary side, I would want them to consult me and talk to the provider about exactly what you're doing and the plan.
Yes.
Don't just go willy-nilly cutting your patches.
Yes, don't willy-nilly, whatever. But I often would tell my patients that if they were having financial difficulty getting their patch, so I would say, if they were on a 0.05, let's do a 0.1 and we'll cut it in half. So we're going to take a little break right now and calm our nerves, and we'll be right back with lots more information, so stay with me. Welcome back. We're going to continue this discussion, and it's good. It's going to be good.
So the other thing, Dr. Miller and Karen, that y'all were talking to me, I'm just the ignorant veterinarian, so I learned a lot about these things. They were running through the benefits of HRT. And in veterinary medicine, if we see a 5% improvement, that's pretty good. Like we like that. And anything above 5%, 10%, we're doing really good. Like that's a treatment that we're going to focus on that can help our patients. So what kind of improvements do you see with HRT now?
Well, as a person who is an expert in that area, my goal always is to have them 100% relieved of their symptoms. A lot of that involves some really good listening and knowing how to dose different products in a way to try to make that happen. I would say, though, I typically could get people to feel 80 to 90% better.
Which is big.
But that was also because I worked hard to do that. I mean, I learned a lot over the years. I studied over the years. I listened to patients and people's symptoms and what makes them better, what makes them worse, rather than worrying just about labs. Far more successful. When you start treating labs, you're in trouble. You're in trouble. You got to listen to people. When it comes to hormones.
Treat the patient, not the paper.
Exactly, especially with hormones, because the range of normal is huge. And where you feel great is not where the person next to you feels great. Even with patches, estradiol patches, which we have several doses, and you think, well, that's great. But if I told the women of the world that there are 7 bra sizes and you got to just find one that fits you as close as possible, people would be burning mattresses in the street. I mean,
or bras,
something. They've been burning something. We accept that there are only these few doses for women and for men to replace hormones. And that's one of the many reasons I got into compounding, because there are infinite number of doses with compounding.
Right. And then Dr. Miller, can you give us some statistics on cardiac disease benefits?
Well, I think as we were talking, the thing that sort of was sticking out with me is sort of the American College of Cardiology did that 2019 systematic review based some evidence on that. And basically came out with a statement that said if your cardiovascular risk was less than 5%, then consider transdermal therapy. If your cardiovascular risk was 5 to 10%, consider transdermal estrogen, and those with greater than 10% should consider no hormonal option at all. Tell me, Kara.
I'm trying to remain silent.
Not for long.
Tell me your perspective, because people that take care of HRT send people for me to say yes or no. And there have been people historically who, usually men in cardiology, who have made commentary about no HRT based upon the WHI data. And so I guess I would be interested in your thoughts about that perspective and point.
Well, think about what estradiol does for our body. It makes things stretchy and flexible, including arteries. So if we have less arterial stiffness, our arteries function better. If our heart muscle is more flexible, it functions better. So it's not just about the flexibility, which is a big deal. Our cholesterol numbers go up when we don't have hormones, because our hormones are made from cholesterol. So when we don't have hormones, our brain goes, oh, what the heck? She has no hormones. She must not have goop to make hormones. Well, let's make some more goop, and then she can make hormones. Levels naturally go up, which increases your risk for cardiovascular disease. I mean, we have studies now that show that estradiol is heart protective.
Yeah, and so I think my point to asking that is this whole delineation between should I do oral or transdermal or just transdermal or not at all.
Okay.
And I think, again, that's what people are asking me as a cardiovascular expert. They're wanting me to say to them, you should not do oral therapy because you have pre-existing coronary artery disease and stents. You should only do transdermal. Now, I would be somewhat reluctant to tell any female person that no therapy at all would be okay, right? So it puts me in a bit of a position, number one. Number two, the risk calculator for that. How many people actually on these women who need HRT are running the risk calculator and putting it in their documentation to say, well, I've calculated your risk based upon these variables, and for HRT, this is where you resign.
Here's what I would say about those things. Definitely if I had someone, and I did, if I had people who had heart disease or personal clot history or family history of clot, I would never put them on oral estradiol. I always use topical. And as a way to, not saying to protect yourself as a practitioner, but just to monitor what risks are happening if you're on transdermal estradiol, just draw a fibrinogen level. It's not that big a deal. I would monitor fibrinogen levels in those people. Now, also, it's so individual. If somebody came into you with new diagnosis of heart disease and they're already on some kind of hormone replacement, I would say, okay, you're on oral form of estrogen. I know there are benefits, cardiac benefits for women being on hormones, but we need to reduce your clot risk, and we can do so by giving you a transdermal version of estradiol. If somebody came to you and they were just diagnosed with heart disease, or you've just diagnosed them with heart disease and they're 73 years old and never been on hormone replacement therapy, or they were on hormone replacement therapy from age 51 to 58, and they said, can I do hormone replacement therapy? I heard it would be good for me. I'd be like, yeah, what symptoms are you having? And why would we want to start that at this point?
Based on the age?
Based on, and not being on hormones all this time, we see the most benefit in terms of hormone replacement therapy if women are on HRT, specifically estradiol, in the first 5 years of menopause. And now we're even seeing that it's more beneficial to start it in perimenopause, just before you go into menopause. Not to say that you don't get any benefit after 5 years, but the really meat of it, the meat of the benefit, is in those first 5 years.
During the transition. So would you ever...
Well, once they get into menopause.
Would you ever use oral hormone replacement? Or we started saying that the patches and the topicals are the way to go. And then Dr. Miller brought up oral and heart disease and their higher risks with oral. So would you, as a practitioner, where would you put in oral? It sounded to me like you would always use topical.
So I want to chime in a bit. This plays into the underrepresentation of women with cardiovascular disease and the number of studies that have been done. And so you look at the subpopulation of women who have coronary disease and stents, and they're on aspirin, they may be on Plavix, they may be on anticoagulation therapy. And what does that subgroup analysis look like? We really don't know. And so then risk benefit. So then the addition of anticoagulation or antiplatelet therapy to that group of women may alter treatment.
Right. I mean, if you're saying, look, we're already anticoagulating, adding on topical estradiol isn't going to increase your risk. You're already
treated.
You're already treated. And I would also, as you mentioned about symptoms, I also would look at, is this person miserable with night sweats and hot flashes? And cardiologists don't want women who have heart disease to have high stress hormone levels. Yep. And if you want to see high stress hormone levels in a body, check it out in a woman who's having hot flashes and night sweats and anxiety and fearfulness and, on and on and on. You're better off to make that woman comfortable and happy, because that plays into their cardiovascular health as well.
Yeah, I get a ton of women who come with vasomotor symptoms.
Those are hot flashes and night sweats.
Thank you. And then they think they're having a heart attack or they're dying because those symptoms are severe sometimes. And so I think that balance of treating vasomotor symptoms appropriately and doing appropriate cardiovascular risk assessment in those patients really becomes a balance that we have to make.
Well, and I think that if cardiologists are just afraid to prescribe hormone replacement therapy because they're not knowledgeable, then they either need to get knowledgeable or refer on to someone who is. Because the one thing I really don't want to hear is a patient coming back and saying, oh, I saw my cardiologist and this has happened to me. I've seen my cardiologist and they said I shouldn't be on hormones.
Well, and was there a risk calculator run? So did we look within the evidence and balance that out with risk calculator?
You're talking about a risk calculator. Is this something I can pull out of my pocket and type in numbers, or what are you talking about?
So in general, there are a lot of risk calculators out there for cardiovascular risk assessment.
So like an app?
It's an app.
Okay.
And so most people can pull those out pretty quickly. MedCalc is one of the apps where you can find most of the risk calculators. And I'm sure on some of the women's health websites, there's probably a cardiovascular risk calculator. I think that's important, that if someone has risk and wants to be treated, needs to be treated, that the risk calculator calculation be done, and that be discussed with the person, and then we weigh risk benefit as we do with anything.
Right. But I think that's one piece of the problem solving. And anybody who does that and says, oh, you are seen at too high risk because you're 1 point over, you don't get hormones.
Tough it out.
They're not, and get dismissed and told they can just buck up and deal with it.
Yeah.
Nobody wants to be treated based on one calculator number. We're going to take a little break right now, and we'll be right back, so stay with me. Welcome back.
So this leans into one thing I wanted to ask you, which we haven't discussed yet, which is the timing of therapy, because that became an issue with this most recent analysis of the data. And so, current recommendations on how long do we take this, and when do we stop it, or do we stop it? Or
so can I jump in? So a few sentences before we went down Dr. Miller's calculator rabbit hole. So I was saying that 5 to 10% benefit in morbidity of various diseases is really impressive. And before we got on here, Karen, you gave me a list. It blew my mind of the level of diseases, morbidity rates that change with HRT. Can you run through that list?
This is in response directly, actually, to how long should we be on hormones, because the other thing that happened with WHI is you should be on hormones for 5 years and then come off.
That's correct.
Which is...
That's what I
told my patients when they ever asked me this, I'd say, look, let's treat you. Let's treat you. If risk factors change, if your benefits change, or at some point you want to go off of it and we titrate you off and you're doing great. I am not going to tell you you're coming off of this in X amount of time. I'm not going to do it because I am not cookie cutter. I'm not a factory. I treat people as individuals. And I've always believed this. And I had women in their 80s that if I took them off their estradiol patch, they were sweaty, angry messes.
Sweaty and pissed.
They were sweaty and pissed for sure. And I would just put them back on. It's fine. I don't care. I mean, why in your 80s, if you're miserable because you don't have your estradiol patch, why are you doing that to an 83-year-old woman? I mean...
So one of the things you've taught me, Karen, in, the years that we've known each other is I've been very much trained in epidemiology, so herd health, big populations. And all of these studies look at 10,000 people, 500,000 people, and what's best for a population of America. One of the things I've been very impressed with you is what's optimal for the individual patient that's in your exam room. And that's kind of what you're referring to now, is that, the studies say this and we're going to take that into account, but what are you feeling day to day, and what's best for you may not be necessarily what the epidemiological studies say. Right. But give me that list of the benefits, because that blew my mind.
Yeah, so this is specifically a study that came out in May of 2024 in the journal Menopause. It was looking at women over 65, and they looked at 10 million senior Medicare women.
That's a lot, folks.
And they looked at it based on the prescriptions used and the visit records. So they were looking, it was chart review. They're looking at the chart, and they looked at the effects of different preparations of menopausal hormonal therapy on all-cause mortality, 5 cancers, 6 cardiovascular diseases, and dementia. So they examined those areas, compared with those women who never used or discontinued menopausal hormonal therapy after age 65 years. The use of estrogen monotherapy, so we're talking about just using estradiol, beyond the age of 65 years was associated with significant risk reductions. And I know this is a lot of your patient population, Stephen, 65 years and older. Mortality risk reduction was reduced by 19%.
So that's death.
death.
19%. 5 in 10 is impressive. 19.
Breast cancer by 16%. This is all risk reduction. Lung cancer by 13%. Colorectal cancer by 12%. Congestive heart failure by 5%. Clots in the veins, 3%. Atrial fibrillation by 4%. Heart attack by 11%. And dementia by 2%. And among senior Medicare women in general, risk reductions appear to be greater with low rather than medium or high doses of estradiol, and by using either vaginal or transdermal rather than oral HRT, and using bioidentical estradiol rather than conjugated estrogen, which again, that's what was in the WHI study, was Primer.
So this is a retrospective cohort study, and so
of 10 million women.
10 million women, which is a huge population. And so I guess really you'd be interested in subpopulation analysis on that group of people.
You can ask them. 10 million. That's a lot of questions.
Kara just gave me a look like, Stephen, I'm going to strangle you.
I'm going to strangle you with this microphone cord. It's super handy.
No, I think the scientist in me right now, I'm not living with the issue of lack of estrogen and vasomotor symptoms. I'm not living that. Right. But just the scientific brain of me wants to know, among the 10 million women who had those benefits, how did that break out? How many had cardiovascular disease pre-existing? And I know I'm going down a rabbit hole a bit, but I think on this side of fairness, I do think that it's important to say and preface this with, this group of women included these people.
Well, and I'll send you the whole study. Okay, try to, for the listeners, I try to share the conclusion.
Yes.
Because I don't know that people are tuning in to hear every last detail of a study, but there are all those things in there.
Yeah, no doubt. Yeah. Like in that group of women at that age, I know that the subpopulation analysis includes AFib and atherosclerotic disease and this and that. I think, and this might be a nice follow-up for the podcast, to look at that, and just because I might dare say there might be some increased benefit in those subpopulations.
Oh.
Right.
Well, you mean the risk reduction numbers would be better,
right,
in certain populations.
That's right.
Yeah, I get that. And I guess I bring this up, especially with you, Stephen, who works in cardiology, to know that if somebody who comes in to see you, a cardiologist, any cardiologist, who's 65, 68, and they've been on hormone replacement therapy and they're still on hormone replacement therapy, they're on an estradiol patch, I hope that nobody's ripping them off that.
Right. And
especially with this study. Because they haven't seen as many as 10 million women, I can tell you that much.
Right. I will tell you, it is not a comfortable consult for someone to send you and say, should I continue the therapy? Much of my job is not comfortable.
Yeah.
But if you do due diligence, especially in light of the new FDA labeling and with retraction of the old information, it is now worthy of having the conversation and going in and looking yourself at the data set and the subpopulation and saying to the person, you've got atherosclerotic disease. I ran the risk calculator, which is the ASCVD risk calculator that's put out by the American College of Cardiology and American Heart Association, readily available. And if your risk is this or this or this is what's recommended. I'm not a hormone expert, don't claim to be, but this is on the cardiology side, what's fair and reasonable.
Right. But I would say if you want to have a little bit of a CYA, again, I would just draw a fibrinogen level on them.
Yeah, I agree.
That's the clot risk, period. That's the clot risk, is if fibrinogen levels go up. I've checked these levels many, 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 many times over the years on patients who are higher risk and who are on transdermal therapy because of their risk. And I have never, not once, had a fibrinogen level that bumped up and was always normal, but never bumped up. Never even moved.
With transdermal.
With transdermal.
Yeah. I think in this time where newer And clearly to God, after 24 years of belaboring this, we have really good evidence to say that risk with transdermal therapy is pretty low.
Yeah. Believe me, I was doing this 24 years ago. That's how I started doing compounded hormone therapy, because I had all these women who got yanked off of their hormones and they were miserable wrecks. I thought there's got to be another way. And all we're looking at is Premarin. I have never written a Premarin prescription in my career. Not one. And that's how I started that whole thing was I should be thankful for WHI. Yeah. I'm not, but I should be thankful.
Well, thankful, but maybe 22 years earlier.
I mean, it led me to look at what other options we have, because no one was writing any hormone therapy at that time.
And I think if you're not seeing someone who's interested in hormone-related issues,
right,
then across providers, it's a challenging population that requires a focused evaluation. If that person hasn't had the expertise in that focused area, then clearly there's a broad space for people who care about helping women. Mm-hmm. The vasomotor symptoms are debilitating.
Hot flashes and night sweats, yeah, they're terrible. But that's the tip of the iceberg. I mean, so many women get put on antidepressants because all of the symptoms in perimenopause and menopause are almost identical to depression symptoms. Tired, we gain weight, we have no interest in anything, we have low sex drive, we're fatigued all the time, we have brain fog, we have poor mood, we have anxiety. When you give them that list to a provider, they're like, oh, let's put you on Lexapro.
They're like, do I have my magic wand today? I do have a magic wand. It shoots blanks, but I do have one in my office.
But the easy fix is just put you on this one pill a day.
But then you're just shoving pills at people, right?
Well, and you're not addressing the problem.
Right.
The problem is perimenopause or menopause. And I'm not saying you can't also need an antidepressant, but don't use that as a fix-all for women's hormonal symptoms. That's not right. And that's why I was so busy for all those years.
Now, clearly, I don't think it's treating root cause.
Well, no.
Right. So again, you might need depression medicine for a period of time to get through some of the symptoms. So
Absolutely.
Not underestimating the impact of treatment of depression, but more about focusing on root cause and solutions.
Well, oftentimes new patients, I would probably say at least 60 or 70% of the time when I saw a new patient, they were already on an antidepressant, that they'd never been on an antidepressant their entire life. But the minute they hit like 48, then they needed an antidepressant. And so I would say to them, look, I think your antidepressant was started to address your perimenopausal, menopausal symptoms. We're going to work on fixing the menopausal, perimenopausal symptoms, but we are not taking out your safety net from under you. I'm leaving this antidepressant on board, and when we're ready, we will look to discontinue it and see how you do.
So how much of that was the harm of the black box? The warning that if you were a provider, the antidepressant didn't have a black box, so you weren't going to get into trouble prescribing that, where if you prescribed something with a black box, then suddenly...
I think that's a piece of it.
vulnerable.
I think it's multifactorial. I think it's lazy practitioners, to be honest with you. I think it's lazy care. Look, I have a passion for this, and I always did. And you sort of have to have that. To help menopausal, perimenopausal women, you need a passion. And most people don't have the passion. They don't want to take all the extra training that I did.
And hormones are complex.
And they're so complex. And nobody has the time anymore because it's just a business now. Medicine is a business. If you can't get somebody in and out of the appointment within 15 minutes, you're losing money. So you have to want to spend time with people and that you have a passion to help them.
Treat the patient, not the paper.
That's right. That's right. The long and short of it. That's sort of the long of it right now. I do want to wrap this up, but we didn't get into the other things that are so important in terms of having estradiol as we go into menopause is brain health and bone health. And I've talked about both of those things on previous episodes, so you can always look that up as a listener. But brain health is huge. There is a reason that Alzheimer's hits more women than men, way more women than men. Not that lack of estrogen causes Alzheimer's or dementia, but we are much more susceptible because our brains don't work very well without estrogen. And so that's why we get brain fog and then word recall problems and then dementia or mild cognitive impairment, whatever. There are a lot of pieces of the puzzle that estradiol, just reminding everybody that if you have a uterus, you can't just do estradiol alone. You have to have progesterone too. Having hormones is key in terms of your overall health in menopause. And now we have studies showing that even after age 65, it's super important.
And hopefully this outrage that started this whole conversation will be resolved, and all of the people in need will have access, and providers will step up, and the pharmaceutical companies will start producing, and the insurance companies will stop protesting, and life for everyone can get better.
Right. I think the production is better. I think people are able to get their estradiol patches more easily. So that's good. That's good.
Good.
Yeah. Do you have any last comments, Stephen?
Well, I was trying to find that subgroup analysis. I wanted to have a little wrap in on the end.
Well, we can do an addendum on the next podcast. We'll do that next time, I
That's
promise.
okay. Yeah.
So I want to thank Keith and Stephen so much. This has actually been fun and lively conversation. I really appreciate it. And many thanks to all of you for listening. Wherever you listen to this podcast, please leave a review and rate the podcast. Your reviews and ratings matter. Also, make sure you follow the show so that it will be automatically downloaded. That really matters. I encourage you to visit our Facebook page, IMB Podcast, where you can give us a like and leave comments or questions for me. Our website is itchyandbitchy.com, where there are blogs with some of our subjects available for you to read. Thank you to Forrest Winsel, my son, our producer and composer of our theme music, and the person who does all the behind-the-scenes work to make this podcast possible. And Forrest will be sharing his producing knowledge and expertise with Stephen and Keith to help with the transition.
Thank you, Forrest.
What a wonderful son. Thank you, Forrest.
We need help.
No, you guys are fast learners. You'll be good. Forrest continues to thrive at Peabody Music Conservatory and is finishing up his final semester of the master's program. Forrest was recently informed that he was admitted to the Peabody doctoral program to receive a Doctor of Musical Arts in composition. His dad and I are so happy for him. It is fun to see his immense musical talents being recognized. If you want to listen to what he is creating, you can go to his website, forrestwinsel.com. And always remember that your health is in your hands.